Hello everyone. In this session, I am going to discuss a very important, such a precious topic, that is lung tumors. So let us start the discussion with a very important, typical case scenario, very frequently asked in your university exam. A 60-year-old male who is a chronic smoker for the last 25 years comes with complaints of chronic cough. Past 2 years associated with hemoptysis, that is blood stained sputum, loss of appetite, loss of weight. So of course they are talking about some malignancies. On X-ray, we have a mass on right upper lobe. Yes, this confirms the diagnosis of malignancy. He has decreased sodium levels in blood. He has ptosis and enophthalmos on ocular examination. What is your probable diagnosis? So the lung tumor, probably small cell carcinoma. The examiner wants you to clearly mention what is the type of carcinoma. Don't write it is a lung tumor. Now that even a first standard student will write whether it is a lung tumor or not. The examiner wants you to write whether it is a small cell carcinoma, large cell carcinoma, whether it is a squamous cell or whether it is an adenocarcinoma. Remember, smoking is strongly associated. The strongest association of a cancer with the smoking is answer is small cell carcinoma of the lung. Okay, what is the molecular basis? What is the classification of lung tumor? What is the morphology? What is the reason for decrease in sodium level? Here we have to apply the general pathology. In general pathology, we have read about a lot of paraneoplastic syndromes which are associated with the various malignancy. As far as small cell carcinoma is concerned, the most commonest type of paraneoplastic syndrome associated with small cell carcinoma of the lung, that is nothing else but called as SIADH, syndrome of inappropriate ADH secretion. So patient will have what? There will be excessive ADH secretion, so there will be more sodium and water loss in urine, so the patient have hyponatremia. And ptosis and enophthalmos, since this mass is involved in the right upper lobe, this is going to compress the cervical sympathetic chain. The patient may have Horner syndrome. What are the components of Horner syndrome? Ptosis, meiosis, enophthalmos, anhidrosis, and loss of ciliospinal reflex. Fine. Okay. What are the precursor lesions of lung tumor? This is one of the most frequently asked questions. They may ask this either as a short note question or in essay. What is adenocarcinoma in situ? So at the end of the session, you will be able to find the answer for all this. Then coming to the lung tumor. See, lung tumor classification has undergone lot of evolution, lot of changes. The classification which is given in Robbins, the latest edition, even that is outdated. So what I have taken the direct snap from the book, what we call it as WHO 2021/2022 lung tumor classification. So we have some blue books, we have some Bibles for tumors. Okay, tumor pathology, we follow some Bibles. So one such Bible is WHO's books, okay, blue books. So this is the exact classification you have to follow. Rest all classification which is given in all other books released so far is completely outdated. So first we can broadly classify lung tumors into epithelial tumors and number 2 mesenchymal tumors. As far as epithelial tumors are concerned, you have to just remember adenocarcinoma. Okay, what I am highlighting, just remember those. Next is squamous cell carcinoma. Next is neuroendocrine tumors, and last one is large cell carcinoma. In adenocarcinoma, you have to remember only some variety. One is what we call it as pre-invasive lesion, that we will see what are the pre-invasive lesions in detail later. Lipidic adenocarcinoma, acinar, papillary, solid, and minimally invasive. Then in squamous cell, we have keratinizing, non-keratinizing squamous cell carcinoma. In neuroendocrine, we have small cell and large cell neuroendocrine carcinoma, and carcinoid tumors which may be typical and atypical. So these highlighted things only you have to write. So of course, see the question here, classify the lung tumors. So whenever they ask you to classify the lung tumors under epithelial tumors, you have to write this much. Okay, that carries what? Minimum 3 to 5 marks out of your 15 marks essay question. Then mesenchymal tumors, we have hamartoma, chondroma, picomatous tumors. Okay, PEC, picomatous tumors. Okay, yes. So these are the 3 important tumors that comes under mesenchymal tumors. So coming into lung cancer, which is the most frequently diagnosed, so the major cancer worldwide and the most common cancer which leads to death worldwide is lung cancer. Again, this is an updated. In 9th edition, they have mentioned some other thing. Okay, so as far as the recent edition, latest edition of Robbins, lung cancer is the most common major cancer worldwide and the cancer which is responsible for most number of deaths worldwide. Age group 55 and 84 years is the classical age group with the peak incidence between 65 and 74 years. So of course, see, I have given a case scenario of what is the age of the patient, 60-year-old. Okay, fine. So don't always think that smoking only produces lung cancer. No, we have one variety of lung cancer called adenocarcinoma. Adenocarcinoma is actually called as the lung cancer in non-smokers who don't even touch cigarettes, don't even touch any tobacco items. They will develop this type of cancer, that is adenocarcinoma. And remember, adenocarcinoma, I will tell again later also, it is more common in females than in males. Fine? Okay. So of course, tobacco smoking, 80% incident is 80% lung cancer because of tobacco smoking. We have something called a second-hand smoke. That means someone else will be smoking, we will be standing near it and we will be inhaling the smoke. That is called as second-hand smoke. Again, that is associated with increased risk of lung cancer. Fine. Then we have industrial hazards, asbestos. We will see later. Asbestos is mainly associated with the adenocarcinoma of lung. Okay, and it also causes malignant mesothelioma that we will see later. Arsenic, chromium, uranium, nickel, vinyl chloride. Fine. Okay. And mustard gas increase the risk of developing lung cancer. Of course, asbestos 5-fold risk of developing lung cancer. Air pollution, again second-hand smoke. Fine. All these points just you have to write when they ask about etiology. You have to write all these things. Coming into what is the molecular basis. There is no need that you should elaborate like what we have studied in neoplasia. Just what are the mutations, what are the receptor mutations which takes place in each type of the lung cancer. That is the only one point you have to remember in each type of tumors. Each type of tumor you have to remember, because you will get lot of multiple choice question from lung tumors. First is adenocarcinoma. I already told you it is more common in females than in males. Number one. So adenocarcinoma is a special, okay, he's a VVIP. Okay, here he won't obey the normal rules of lung cancer. That is, it is the most common subtype in never smokers who don't even touch cigarette. No, they develop adenocarcinoma, and it is most commonly associated with two important receptor tyrosine kinase mutation. One is called as epidermal growth factor receptor EGFR, and number 2 is what we call as ALK, anaplastic lymphoma kinase. Okay, ALK. And we have something what we call it as, so that finishes what we call it as our adenocarcinoma. Next, coming into squamous cell carcinoma. In squamous cell carcinoma, the most important is TP53 gene. So of course, squamous cell carcinoma is a little bit worse prognosis only. And of course, mutation of CDKN2A gene. No other way, by heart. See. And okay, the CDKN2A, it's actually tumor suppressor gene, which encodes for a cyclin-dependent kinase inhibitor called P16, and this P16 is mutated in around 65% of tumors. And we have another FGFR, fibroblast growth factor receptor 1, okay, tyrosine kinase. Again, that is also mutated in squamous cell carcinoma. So remember TP53, CDKN2A, FGFR1. Fine. Small cell carcinoma. Remember two things. As far as small cell carcinoma is concerned, small cell carcinoma is the only lung tumor which is having the strongest association. So I'm going to write like severity. Most closest association with smoking. Small cell very much greater than squamous cell. Least is adeno. Of course, it is never. Just some books are saying like 1% seen in smokers. Fine, least. Okay. Then, so lung cancers in never smokers, I told it is adenocarcinoma associated with EGFR mutations. Coming into what are the precursor lesions. So that is the question, right? The 4 precursors lesion you have to by heart. Number 1 is atypical adenomatous hyperplasia. We will see that in morphology detail. Then adenocarcinoma in situ. First 1 and 2 only we are going to discuss the morphology in detail. Rest to namesake. Third one, squamous dysplasia and carcinoma in situ. Fourth one, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. No other way, you have to by heart it. Fine? Fine. Okay. As far as, so actually this pre-invasive lesions has been asked in AIMS May 2019 session. Okay. What are the, all of the following are the precursor or pre-invasive lesions of lung tumors except. Fine? Okay. So coming into classification. Of course, see, this is a outdated classification actually. Fine? Even though if you look, it will look similar like what I have told you. There have been a lot and other changes, okay, which has been not included in this table. So I won't usually ask you to follow this table. The first table, no, I have given, it is a straight pick straight away from the WHO Blue Book. I advise you to follow that. Fine, okay. Then, so mainly we have the most common is adenocarcinoma, followed by squamous cell, small cell, large cell, and miscellaneous. Fine. Coming into morphology, we have something first. We are going to discuss the precursor or pre-invasive lesions. So what are the precursor lesions? That means in future they may undergo malignancy. That is the meaning for precursor or pre-invasive. They are not invasive, they are pre-invasive. Fine. Okay. Atypical adenomatous hyperplasia. So here, what is happening? So this the pathology is in the lung. In the lung parenchyma, we have the alveoles. What is the normal lining epithelium of alveoli? It is squamous. But here it becomes cuboidal. That is the first important point. And there you can see the alveoli are completely filled with the interstitial fibrosis. So atypical adenomatous hyperplasia. The first point you have to remember is less than or equal to 5 millimeter is the size of the lesion. There will be dysplastic type 2 pneumocytes. They are mildly fibrotic. Less than 5 millimeter, dysplastic pneumocyte, mildly fibrotic. Just remember this picture. We have something called as adenocarcinoma in situ. What is that called as? Adenocarcinoma in situ. Formerly, this is actually called as bronchoalveolar carcinoma, but that terminology has been outdated. Now we are using adenocarcinoma in situ. The size here is less than 3 centimeters. Size is very important. You should remember. Again, we have dysplastic cells. Okay, and this dysplastic cells has a characteristic pattern. See, we can see a characteristic growth along the alveolar septum. But there is no invasion because all these are pre-invasive lesions. So there is no invasion there is no breach in the basement membrane. This characteristic, yes, and I hope you can guess. Yes, what is the pattern called as? This is called as lepidic pattern. This is called as lepidic pattern. This is one of the most famous pattern in lung pathology. That is the lepidic pattern, also called as butterfly sitting on the fence pattern. Okay, this is called the lepidic pattern, also called as a butterfly sitting on the fence pattern. Okay, as you can see, many butterflies which will be sitting along so there will be proliferation of the cells along the alveolar septa. So it will mimic. So, for example, so this is the fence I am drawing, and what you are seeing, all these are the butterflies. So this is called as the butterfly sitting on the fence pattern. Fine. Okay. Once this is done, now let us see about the next. So these are the two important pre-invasive lesions. Coming into the cancer proper. So what was the diagnosis in our case? It was small cell carcinoma. Because the history, the patient has been a smoker. So we can't say adenocarcinoma. Adenocarcinoma 99.9% it is seen in non-smokers only. Just 0.1 to 1% is seen in smokers as per guidelines. Okay, fine. So we have adenocarcinoma. Adeno means, of course, there is a glandular differentiation. There will be an abnormal, unnecessary, or what to say, like completely disoriented glandular differentiation. We have poorly differentiated adenocarcinoma, moderately differentiated adenocarcinoma, well differentiated adenocarcinoma. We have different patterns. We have acinar, lepidic, papillary, micropapillary, and solid. Fine. Okay. We have to remember some important features. So they are glands. So glands will produce mucin. So of course these glands will be filled with the mucin. Don't worry, I will show all the pictures. See, first you can see, this is what we call, what you are seeing here is all these are glands. So of course with this single, it's very easy to identify. This is a gland forming adenocarcinoma. Okay, this is a gland forming adenocarcinoma. And of course it is a well differentiated adenocarcinoma. Why I call it as a well differentiated? Because I am able to segregate. I am able to clearly demarcate the different glands. Fine. Yes. Fine. And the second picture what you are showing here, you can see what we call it as keratin pearls. Again, you are able to differentiate the glands proper. So again, it's a well differentiated squamous cell carcinoma. That is what we are going to differentiate next. And so the third one, this is what we call it as small cell carcinoma. Small cell carcinoma, you can see small cells. I am putting dots. These are cells. This is called as the characteristic salt and pepper pattern. Salt and pepper pattern is seen in all type of neuroendocrine tumors. So small cell carcinoma of the lung is also a type of neuroendocrine tumors. If you see, remember the classification that I have shown first. If you forget, just go back to the video and see the classification. Neuroendocrine tumors only small cell, large cell, carcinoid, typical and atypical carcinoid, all comes in that. So all neuroendocrine tumors, whether it is in lungs, whether it is in heart, whether it is in stomach, everywhere we will see the characteristic pattern called a small, salt and pepper pattern. Okay, that is, okay, you will see like clumped nuclear, you can see basophilic cells with a clumped nuclear chromatin. Fine. Okay, and this is the large cell, pleomorphic, and it's actually, there will be no squamous or glandular. So not squamous, not glandular, not neuroendocrine. We will put it into large cell. Fine. Okay, just I have familiarized with the picture. Coming to adenocarcinoma again. So all these are mucin because glands. So glands produce mucin, and remember we have some transcription. We have some markers, immunohistochemistry markers for this. One is called as TTF, that is thyroid transcription factor 1, and another one is called as napsin E. These are the two important IHC markers for adenocarcinoma. We have something what we call it as micro-invasive adenocarcinoma. Micro-invasive adenocarcinoma means when the invasive component is less than or equal to 5 millimeter. Okay, and the tumor size is less than or equal to 3 centimeter. We call it as micro-invasive adenocarcinoma, and it is having a good prognosis. Okay, the prognosis is better than the invasive type of adenocarcinomas. Fine, because the invasive component for invasive type of adenocarcinoma will be more than 5 millimeter. Why it is called as micro-invasive? Because the invasive component is less than or equal to 5 millimeter. Squamous cell carcinoma again strongly associated with smoking. Already I have told you. So we'll have squamous metaplasia, dysplasia, in situ. All these are the precursor lesion. Finally, all this will convert into what we call it as squamous cell carcinoma proper. So histologically, wherever we see squamous cell carcinoma, what is the first thing you will write? Very good, keratin pearls. So you will get keratin pearls. Of course, remember this keratinization or keratin pearls is only well appreciated in well differentiated tumors. Again, we have moderately and poorly differentiated tumors. Whatever tumors they ask, just write. If it is squamous cell carcinoma, first point you write is the presence of keratin pearl. Then write we have well differentiated, moderately differentiated, and poorly differentiated keratin pearls. Keratin pearls are only well appreciated in well differentiated squamous cell carcinoma. And we have squamous metaplasia, dysplasia, fine, all those things. Again, normal thing. Just remember very, very important thing. The two important IHC markers. IHC markers we have for squamous cell carcinoma is what we call as P40 and P63. Of course, cytokeratin. Of course, cytokeratin. Cytokeratin is present in all squamous cell carcinoma. All epithelial tumors will express cytokeratin. Fine. So all squamous cell carcinomas also exhibit cytokeratin. So it is non-specific. So we are discussing squamous cell carcinoma of the lung. So lungs means mainly they will express P40 and P63. Fine. Okay. Coming into squamous small cell, even though it is a small cell, it is having the strongest relationship with the cigarette smoking. Only 1% seen in non-smokers. Fine. Okay. So it is mainly affecting the major bronchi and the lung periphery. Okay, it is the most aggressive of all lung tumors. It's like a fatal lung tumor. Okay, the patient has all the complications and usually the prognosis is very poor. The life expectancy of the patient won't last for weeks or months. Fine. So it is characterized by, as a name indicates, small cell carcinoma. So you will have relatively small cells. I told you, these are small cells. You can see this is a characteristic salt and pepper pattern. So these cells are described as round, oval, or spindle-shaped cells with a nuclear mounting. They are deeply basophilic cells. We are having clumped nuclear chromatin, and so it will be the arrangement of cells won't be either glandular arrangement or there won't be any squamous arrangement. That is why we call it, put it in a different entity. And we have a very, very important phenomenon. We call it as Assopardi effect. That means because the tumor cells they will undergo necrosis and they will undergo encrustation. So they will undergo rupture, and the nuclear content, which is basophilic, will come out, and this basophilia will stain the vascular wall. So the basophilic staining of the vascular wall because of the encrustation of the necrotic tumor cells due to release of DNA, which is basophilic, that is what we call it as Assopardi phenomenon. That is what we call as Assopardi effect or Assopardi phenomenon. Then, as seen in all neuroendocrine tumors, we have three important IHC markers. One is synaptophysin, then chromogranin, and CD56 or neuron-specific enolase, NSE. These are the three important markers. Wherever in our body they asked about neuroendocrine tumors, please write all these things. And electron microscopy shows dense core neurosecretory granules. Fine? Okay. So, of course, I told about this. You can see this characteristic salt and pepper pattern. See what I am going to draw with the black color. I'm going to draw. This is the base. This is the vascular wall. So you can see the basophilic staining of the vascular wall. This is called as Assopardi effect because of incrustation of DNA from the necrotic tumor cells. And DNA is basophilic. Coming to large cell carcinoma, so they won't express any markers of adenocarcinoma, squamous cell carcinoma. We can't include them into neuroendocrine tumors. So we put in a different category called as large cell carcinoma. Not that much significant. So all these are the precursor lesions. Fine. Just okay. So this you can see what we call it as these are actually various stages of dysplasia. Okay, we can see the various stages of dysplasia. This is a classical what we call it as the stage which is immediately behind the before the invasive squamous cell carcinoma. This is the invasive stage. This is the invasive stage. Just a comparison. Okay, don't bother. So this is cytological change. What you are seeing is a keratinized squamous epithelial cell. So this is a gross picture. You can see. So gross morphology we have not written it. It's a grey white tumor. Okay, which infiltrates the lung parenchyma. Fine. And so that's a grey white tumor. Nothing else we can see in gross. Of course, all we are going to differentiate what type of tumor, everything, all those steps only by microscopy. Fine. Then what are the other associated conditions with the lung? Of course, the patient have emphysema, atelectasis, that is collapse of the alveoli, superior vena cava syndrome, pleuritis, Horner syndrome. In this patient, the patient have Horner syndrome because if this mass is mainly present in the right upper lobe of the lung, this will compress the cervical sympathetic chain leading to Horner syndrome. The patient have meiosis, ptosis, anhidrosis, anaphthalamus, loss of ciliary spinal reflex, all those. So that also Horner syndrome with the right upper lobe tumor, we call it is actually called as a Pancoast tumor. Okay, what is it called? Pancoast tumor. Then coming to international staging system. So as far as secondary is concerned, there is no need for you to remember the staging for lung tumors. Fine. So clinical features, most common presentation. Everyone will think that most common symptom of lung cancer is blood what is hemoptysis. The answer is wrong. 75% will have cough, then weight loss, chest pain, dyspnea. Very few will have hemoptysis. Fine. Okay. So what are the local effects of lung tumor spread? So cough, because of that, why cough? Central airway involvement. Hemoptysis, the tumors, hemorrhage. Chest pain, the tumor may extend into mediastina, pleura, chest wall, irritate the nerves. Pneumonia, because of airway obstruction. Pleural effusion, when the tumor spread into pleura. Hoarseness, dysphagia, all this because of recurrent laryngeal nerve invasion or compression of esophagus. Then diaphragm palsy because of phrenic nerve invasion. SPC syndrome, Horner's syndrome, I told you, cervical sympathetic chain, pericarditis and Tamarin because of pericardial improvement. So all these are clinical features, okay? But don't expect in your university exam, they won't give all these clinical features. They will be just chronic cough, weight loss, X-ray shows right upper mass. That's all, fine? Okay. So as far as paraneoplastic syndrome is concerned, lungs carcinomas are one of the worst carcinoma, because that's the way I told you, it is a carcinoma which causes the most major number of deaths worldwide, because almost all the paraneoplastic syndromes are associated with lung cancer. Out of that, we have ADH, antidiuretic, that is SIAD, syndrome of inappropriate ADH secretion, which is most commonly associated with the small cell carcinoma, which is most commonly associated with small cell carcinoma of the lung. Then Cushing syndrome is associated. Then in squamous cell carcinoma, SCC, squamous cell carcinoma, the paraneoplastic syndrome which is associated is hypercalcemia. Then we have, of course, what we call it as Lambert-Eaton myasthenic syndrome. Okay. Then peripheral neuropathy, acanthosis nigricans. Okay. And hypertrophic pulmonary osteoarthropathy. This is most commonly associated with the SCC, squamous cell carcinoma, and malignant mesothelioma. So forget about Lambert-Eaton and all those. Remember what I have written. Okay. Squamous cell carcinoma mainly associated with hypercalcemia, malignant mesothelioma and all, which is most commonly associated with what we call it as a hypertrophic pulmonary osteoarthropathy. That is the 4th grade of clubbing. You would have read in medicine. And next one is what we call as ADH. SADH is most commonly associated with small cell carcinoma. That is why our patient in this case scenario have SADH. So more ADH, more water and more sodium will be excreted in the urine, and the patient will typically present with a low sodium level. The patient may collapse. The patient may be like dizziness. Okay, the patient may even go for coma if not intervened properly. Fine. And ptosis and ophthalmos because of Horner's. Compression of cervical sympathetic chain. Precursor lesion discussed, but atypical adenomatous hyperplasia, adenocarcinoma in situ, and the rest too. Fine. And what is adenocarcinoma in situ? Remember the size, okay, less than 3 centimeter. If it is micro-invasive adenocarcinoma, the invasive component should be less than or equal to 5 millimeter. This is centimeter, that is millimeter. So I think that finishes a detailed discussion of lung tumors. You should remember each and every point, Asopati effect, okay, what carcinomas are associated with smoking, not associated with smoking, all those, because you can get multiple number of MCQs, okay, and of course you will get short notes or even a long question in your prof exams. So thank you.